Good afternoon. I'd like to thank the organizers of this session for inviting me to give this talk. We're going to spend the next few minutes going over autoimmune hepatitis and covering sometimes the challenge in diagnosis, as well as look at our various treatment options and management of these patients. I have nothing to disclose, and so let's go ahead and get started with autoimmune hepatitis. These are those individuals, as they come into your clinic, they can provide a variety of ways of presenting, all the way from asymptomatic or someone with a little elevated in liver enzymes to someone in acute liver failure or severe acute autoimmune hepatitis. So when we look at this, the definition, autoimmune hepatitis is basically a chronic, progressive, immune-mediated inflammatory liver disease. It's typically more common in females, and as I mentioned, they can present either asymptomatically or mild non-specific symptoms such as fatigue, or all the way to presenting with some jaundice or features of more advanced liver disease. Commonly, you will see elevation in liver enzymes and an elevation of serum IgG levels. And it is also important to recognize that about a third of these patients in adults will present already with cirrhosis. There are two different types that we'll discuss, and the prevalence rates are actually increasing. In general, it's considered a rare phenomenon or disease. However, we are seeing increased rates, and I think we have a presentation in this session related to drug-induced injury, and it is possibly increasing because of this effect. A little bit on the pathophysiology of autoimmune hepatitis. We certainly see the impact of some genetic factors. There's been some HLA-specific typing on the different loci that are associated with autoimmune hepatitis. But we also think of things like environmental factors, infection, various toxins, drug-induced injury, that then will lead to an immune-mediated cascade of events which are influenced with T cells as well as B cells, causing inflammation. So it's the immune cells that then get into the hepatocytes causing the inflammation, and if left unchecked will lead to more fibrosis in the liver, possibly cirrhosis, and possibly risk of HCC. As I mentioned, there are two subtypes. The most common subtype is the type 1 autoimmune hepatitis, making up about 80% of our cases. The onset for these individuals is typically in adulthood. The female-male ratio is more common in 4:1, female to male. This does have the potential of having cirrhosis at the time of diagnosis. And I've listed here the autoantibodies that you would check in someone to identify a type 1 autoimmune hepatitis. The type 2 autoimmune is certainly more rare and seen more in childhood. These are your pediatric cases or could be early teenagers. Even more prevalent in females to males. Rare to have cirrhosis at diagnosis. And this is where you add the liver-kidney microsomal antibody as part of your workup panel if you're looking for it. Do you have a type 2? Diagnosis of autoimmune hepatitis can be very challenging, as it's often confounded with other etiologies of liver disease, such as the ones I've listed here, as well as concurrent autoimmune diseases. Most commonly, you think of IBD, ulcerative colitis, Crohn's, or thyroid deficiencies as well. So overlap syndromes is certainly something that confounds our diagnosis, whether we're dealing with an autoimmune hepatitis or also do we have some overlap with either our metabolic dysfunction-associated liver disease, our PBC, our PSC, and then our drug-induced injury. So the next two speakers are going to address those three areas there. So AASLD guidelines recommend the exclusion of other causes of liver disease as part of your workup. So what kind of workup do we do for these patients? First of all, I start with some clinical evaluation. Like I mentioned, it could be nonspecific fatigue. Fatigue's hard, right? We're all fatigued. But certainly if you're seeing an acute case or a sudden onset, you could have an individual that's presenting with severely elevated enzymes and jaundice and features of more end-stage liver disease. Risk factors in assessing, look for family history as well as those autoimmune diseases. And then I've listed the laboratory evaluation, liver function test, the serum IgG, which will be elevated, usually 1.5 times normal, upper limit of normal, and then looking at your autoantibodies there. However, note that 20% of our patients with autoimmune hepatitis will be seronegative. I think this is a great path of diagnosis for you as you're thinking about not only overlap syndromes, but looking at if you have a case of suspected autoimmune hepatitis, certainly excluding those other causes such as viral hepatitis, your drug-induced injury, alcohol use are all things to think about, as well as looking at your lab values. The top of the slide there, you can see your antibodies that you're checking. And then if those come back negative, then there's another panel of some antibodies that you'll look for, which would include the SLA. If the SLA is positive, then you're looking most likely at a diagnosis of autoimmune hepatitis. However, if your AMA comes back, now you're leading into the diagnosis of a PBC, and you may have an overlap. If they're all negative, you might consider that you have one of these cases where you've got a seronegative individual but really has autoimmune hepatitis. So you can see in the center there how key the role of the liver biopsy is in helping you make this diagnosis to really help you understand whether you're dealing with a true autoimmune hepatitis or if you have some overlap. So some of the other causes that you would rule out, this P-ANCA can be positive with autoimmune type 1. However, you can also see this in Crohn's disease. You certainly want to rule out celiac disease, and like I mentioned, the AMA for our PBC individuals. So many of us in hepatology have gotten away from doing liver biopsies, and oftentimes it's a crucial conversation in these individuals with your patients as you're leaning towards a liver biopsy. When it is needed to make a diagnosis of autoimmune hepatitis, and what you'll see on the pathology or the histology is an interface hepatitis with plasma cell infiltration, and that is what helps you make the diagnosis. Here on this slide, there are several black arrows that indicate the interface hepatitis as well as the plasma cells. So you have white arrows, and see if I can get the pointer there too. All right. Sometimes it's hard to see those white arrows on there, but this is classic signs of an autoimmune hepatitis. So there's been 2 scoring systems that have been developed. This is the International Autoimmune Hepatitis Group. The scoring system was developed in the 90s and helps you as you're looking at your various areas to help you make the diagnosis. The first area you look at is your ALK-Phos and your AST ratio, the IgG levels, like I mentioned, your autoantibodies, exclusion of other causes, your liver histology, which gives you a total score calculation. If you have a total score, each of these have different point values associated with. If you have a score greater than 17, then you're most likely dealing with a case of autoimmune hepatitis. There also is a scoring where it would give you a probable but not definite diagnosis. And then in 2008, there's a simplified diagnostic criteria for autoimmune hepatitis, which may be useful in our clinical settings. Know that this has less specificity and sensitivity, and you're looking for a score of greater than 7 to give you your diagnosis here. This is an algorithm for you to have. I won't go into detail, but it does give you your evaluation when you have signs of cholestasis in individuals and thinking through not only what the biopsy is, but adding imaging there, whether it be an MRCP or an ERCP, as well as using your laboratory findings to help you understand. The importance of really understanding what you're dealing with is then going into how are you going to treat this patient and long-term management for the individual. So let's talk for a few minutes about our options in treating individuals. The goal is really to regulate the dysfunctional immune system and turn off that immune disorder. Our goal in treating is for complete biochemical response, which is measured by looking at the AST and the ALT level. And I'm sure we're going to hear from the other presenters as well. We all know the more we can drive this into normal levels, the better it is, whether that's with first-line therapy or thinking of second-line therapy. IgG levels should also be monitored periodically and will help you understand your response to treatment. Here's the list of medications that can be used, and we'll go through a few of these. Before we get to the medications, this is a study that really, I think, highlights the importance of looking for normalization of liver enzymes. It's associated with a better long-term survival in autoimmune hepatitis. The IgG of note was not associated with survival in the first 12 months in this particular study. However, it does show that the more you can normalize liver enzymes in these individuals, independent of their age or cirrhosis, leads to long-term survival. If caught early and with appropriate treatment, these individuals will have a prognosis or a life expectancy similar to the normal population. So our first-line therapy is really steroid induction therapy. So depending on the severity of the autoimmune hepatitis that you're seeing, you can decide on dosage. If you're dealing with a more severe case, you would use 60 milligrams a day or greater. Certainly then in cases that may not be as, the enzymes are not as elevated, you can consider a lower dose than that. But you definitely want to give them an induction therapy, and then with the goal of putting them on maintenance therapy with the goal of providing non-steroidal immunosuppressants. So your first-line therapy is really with steroids, the prednisolone or prednisone. Bunusamide may be used as a first-line alternative, usually with azathioprine. However, note that you shouldn't use this drug in acute cases, acute severe autoimmune, and certainly avoid it in someone with cirrhosis. Azathioprine has been used and is used as a steroid-sparing agent. The dosages of this can be weight-based, so 1 to 2 milligrams per kilogram per day, or also in the guidelines, it's 50 to 150 milligrams per day. The guidelines also highlight, and studies have highlighted, the importance of testing for metabolites and metabolism for individuals with azathioprine. If they have certain mutations of their enzymes, then they will be more prone to developing toxicity with the azathioprine and myelosuppression. So certainly considering altering the metabolism may impact rates of response to treatment. And there's a study published in the Journal of Hepatology this month that looked at the importance of monitoring these levels, as well as the addition of allopurinol, which may, with allopurinol and low-dose azathioprine, lead to improved response rates. Certainly monitoring, if you're going to keep someone on Imuran or azathioprine for long term, you want to think about the bone marrow suppression and because of the immunosuppression, the increase in their cancer risk, especially skin cancer. All right, our guidelines for mycophenolate mofetil, we can use this as a first line, and we can also use this as a second line agent, especially in individuals that may be intolerant to azathioprine. It is associated with better outcomes in treatment-naive individuals, and a recent meta-analysis of 12 studies showed the response rate of a 58% with mycophenolate mofetil, certainly in greater response to those who were intolerant versus somebody who is not responding to azathioprine. Of note, this is tetragenic, and so avoiding in women of childbearing age or certainly in pregnancy. So some second and third line therapies here. Tacrolimus, those of us that have worked in transplant are pretty familiar with this drug, and we use it all the time. In patients that are refractory to standard therapy, this is a good option that's safe and effective. There was a pooled systematic review of 7 studies, looked at the biochemical response rate using tacrolimus, about 75%, so it does show effectiveness. Usually you run the levels of somewhere between 1 and 10. Now, some of the biologics can also cause hepatotoxicity, so it's interesting to think about using a biologic for an autoimmune hepatitis. And there's been some small studies with small n's, but certainly looking at this as a potential use, as well as some of the drugs that are in clinical stages. There was a nice paper published by Nancy Rowe earlier this year that showed 4 different agents that were in clinical trials. I think we're down to 1. And so it remains to be seen in the future of what will be our autoimmune hepatitis treatment. However, certainly we're all hoping that more promising drugs can be developed in this area. There is one that's finishing in a phase 2 trial, and it's a selective immunoprotease inhibitor, and so we'll watch for that data to come. So in long-term management of these patients, just remember that this is someone that you're going to see at periodic intervals depending where they are in their stage. It will go into remission. There might be something that will flare this, and so they will require long-term monitoring for care as well as management. Certainly individuals that are on steroids and continue to have steroid use are going to be at risk for diabetes, metabolic dysfunction, and osteoporosis, so thinking about management of those things, as well as assessing your biochemical response, and then reassessing if you're not seeing the response that you're aiming for, and think about things like adherence and/or do I need to look for second and third line options for my patients. And then always remember the underlying liver disease and where that stage is, and appropriate management for those individuals that have more advanced stage. This is an algorithm that gives you an idea of how often to check. So certainly if you're looking at, if you start your steroid induction and you're adding your medications, checking labs within those first 4 weeks. If you've got great biochemical response, maybe you're dealing with a rapid responder, certainly 8 weeks, but a lot of times we're not really looking at response until about that 6-month marker. And these individuals will need frequent lab monitoring until you've got them under control, and certainly maintenance therapy. There are some individuals that you may consider withdrawing medications completely, but be careful of watching for those flares or remission or relapse in those patients. So in summary, for key takeaways, autoimmune hepatitis is a chronic progressive autoimmune inflammatory liver disease. With early diagnosis and effective treatment, prognosis is very good. Patients with advanced disease and/or inadequate response to therapy will need additional support in disease management, and long-term follow-up for these individuals will be necessary so that we can continue to need better therapies to improve the outcomes of our patients. Thank you very much.
Thanks, Renee, for that great talk. I'm going to introduce our next speaker, Ms. Ann Moore, nurse practitioner from Arizona Liver Health. She's going to be talking about other autoimmune liver diseases, specifically PBC and PSC.
Hi, everyone. Thanks for turning out. I'm Ann Moore. I'm a nurse practitioner at Arizona Liver Health. And here we go. Thanks to the organizers for inviting me to speak today on the other autoimmune liver diseases, diagnosis and management of primary biliary cholangitis and primary sclerosing cholangitis. So as usual, with me, too many slides, too little time. So my objectives today are to leave you with a few pearls, and hopefully, and if I fail at that, remember it's only 20 minutes out of your life. So I'll do my best though. So these are my disclosures. So as most of you know, PBC is a chronic autoimmune progressive disease. We don't really understand the cause fully, but we know it's influenced by both genetics and the environment likely. It triggers an immune response in people, which then targets bile duct, intrahepatic bile ducts, and causes damage over time, which can lead to cirrhosis. In fact, if left untreated, about 50% of patients will develop cirrhosis after 4 years. And so this is a disease of women 9-to-1 over men. It's an uncommon disease that is common in my clinic, but 1 in 1,000 women over 40 have PBC globally. So when you think about it, it's not that rare. Prevalence is increasing, and I think also in men. So if you have males in your clinic with an elevated ALK phos, don't forget to think about PBC. So PBC diagnosis is as easy as 1, 2, and sometimes 3, less and less 3. It all starts with an elevated alkaline phosphatase level of 1.5 times upper limit of normal typically. If you have that and you have the presence of anti-mitochondrial antibodies or other PBC-specific autoantibodies like SP100 or GP210, which are commercially available if your AMA is negative, you have the diagnosis of PBC with just those 2 things. If you don't have those 2 criteria, but you're still thinking PBC, you can go ahead and get a liver biopsy to further substantiate the diagnosis or to rule out other concomitant liver diseases. So clinical presentation is variable. A lot of patients show up in my clinic with just an elevated ALK phos, and then it's up to us to make the diagnosis, right? It can range from really asymptomatic and slowly progressive to symptomatic and very rapidly evolving disease. And so that just highlights the importance of monitoring these patients closely over time and really risk stratifying their disease to keep a handle, especially since we have many choices now for treating these patients. So the most common symptoms associated with PBC are fatigue and pruritus. Those are pesky and persistent symptoms that are difficult to manage in the clinic. But we also see concurrent autoimmune diseases. Autoimmune diseases don't occur by themselves in general. We see them travel together in our clinic. And the most common concurrent autoimmune disease in PBC is thyroid disease. We also see a lot of bone disease in cholestasis in general and liver disease, and PBC is no exception to that. And so patients should be monitored for osteopenia and osteoporosis. We see hypercholesterolemia as well with a predominance of HDL, but don't forget our patients show up with cardiovascular risk as well. And so while we don't think the hypercholesterolemia of PBC is associated with cardiac disease, we do know that if your patient has cardiac risk factors, they are at risk for cardiac disease. So if they have metabolic risk factors or family history, they should be treated as such. We see xanthomas, xanthelasmas, we see depression in these patients, we see sleep disruption. All of these symptoms lead to poor quality of life over time. So probably the most common symptom in PBC is pruritus, and it is sometimes a problem to manage, but hope on the horizon as we have new medications that seem to help with that. So we see pruritus in as many as 70% of patients. It has a diurnal variation. It's most intense typically in the evening and at night. It can be diffuse, but it can also be very localized, oftentimes to the soles of the feet and palms of the hands. It drives people crazy. It's tough to treat, but it's so important to treat it. And it can really help to improve quality of life if you get a handle on pruritus. So it's exacerbated oftentimes by heat of any kind, so temperature, hot showers, contact with wool clothing, tight clothing. It can be worse in pregnancy. And management is really difficult because we don't understand the etiology of the itch. And so there's many targets, and you'll see that most of the targets listed here, we have therapeutic options that target those issues, such as bile salts, endogenous opioids, serotonin, increased levels of lysophosphatidtic acid, autotoxin activity, unmyelinated C5 activation. There's a medication that targets most of those actions, and look at the AASLD guidance if you want more on itching management. So what are our PBC treatment goals? Well, the most important goal is we want to prevent progression of this disease. This is a disease of a lifetime. It doesn't go away, right? And so we need to stop progression. And I would love to see never another liver transplant for PBC. I mean, when I first started working in hepatology, we saw a lot of females coming to liver transplant. That's less and less common. Now we have more options. It is important to get on top of lack of response to treatment and change our therapies and prevent progression. We have a lot of opportunity to improve management of PBC at this point. So while targets are important, we can't forget about the patient along the way. So we sometimes lose ourselves focusing on hitting the medical therapeutic targets and forget that we have a patient attached to the diagnosis. And so really it's important to query your patient at every visit about their quality of life and what's impacting it. Is it pruritus? Is it fatigue? Is it sleep disruption? Whatever it is, find out and attempt to improve it for your patient. So what are the targets of PBC treatment? So, I mean, intuitively, we all know that normal is normal, right? But now we have some good data to back that up from the Global PBC Study Group, which has come out over the last decade, really, which really, it really says that our intuition is right in this case, where normal is normal, and an alk phos that is less than 1 times upper limit of normal is associated with improved transplant-free survival. It's incremental, though, so if you get some improvement, like if you hit that 1.67 target, you're doing well with your patient, but we can do better, right? So in order to really achieve targets, deep remission is what we should be looking at, and that's a combination of factors, including a normal alkaline phosphatase, a bilirubin of less than 0.7, and a liver stiffness measurement less than 8 kilopascals. If you hit that, you are really making a dent in improving transplant-free survival in your PBC patients. So what's initial treatment for PBC? Well, we probably all know this in the room too. Ursodeoxycholic acid has been the backbone of PBC treatment since 1995. We're still using it, still first-line therapy. It dilutes the bile acid pool, and so hepatocytes are less exposed to toxic concentrations of bile. It's dosed at 13 to 15 milligrams per kilogram per day, generally BID dosing. Early treatment provides most benefit. Non-cirrhotics have greater response rate, which speaks to the fact that we need to be diagnosing patients early and getting them on treatment. It's safe to use. Really, most people tolerate it, only about 5% intolerance related to side effects. And we see change in alkaline phosphatase fairly rapidly. So we'll see a quick drop in the first few months and most of the improvement within 6 to 9 months. So I'm begging you to not wait a year. Don't start them on URSO and have them come back in a year to see if they've responded. Like, get on top of this, prevent progression. If you have a non-responder, think about second-line therapy because 40% of people on URSO will have an inadequate response. So what's next for our patients who have suboptimal response to URSO? Well, I want you to make sure it's really suboptimal response before you think of second-line therapy. So as you know, patients don't take their medications, and there's a variety of reasons why, but mostly it comes down to side effects of the treatment you're giving them. And so with URSO, often it's related to weight gain, loose stools, and hair loss, that they're not taking their meds as prescribed. So just ask and make sure they're in line with taking the medication as you prescribed it. Also, a lot of patients coming into our clinic are underdosed on URSO, so check the dosage, that it's weight-based at 13 to 15 milligrams per kilogram, and also remember that more is not better in the case of URSO, so doubling dosage is not shown benefit, so just avoid that. Check for comorbid liver disease because liver diseases don't come by themselves anymore. Think about MASLD, think about MET-ALD, think about concomitant autoimmune hepatitis, and also think about if you're treating itching, if you're using a bile acid sequestrant, is the patient dosing it properly 4 hours apart from the URSO, or are they binding it with the URSO and eliminating metabolism of that drug? So once you've answered these questions and you know that your patient is taking their drug, they're taking it properly, they don't have other liver disease, then consider second-line therapy. And what's up for second-line therapy? I mean, PBC has had a big year this year. It's exciting for me to talk about Finally, something new in PBC. But we have the OG here. The OG is a beta-cholic acid. It was approved as second-line therapy in 2016. It is a farnesoid X receptor agonist. This is an interesting MOA, and it has multiple pathways that impact liver disease, as you can see on your right. It's not just about bile acid homeostasis, but there's other things going on in the liver, so I think it's still an important target. So I don't think we want to lose sight of OCA yet, although I'll probably get some argument on that. The dose of OCA is 5 milligrams to start, up titrating to 10 milligrams at 3 months based on response and tolerability. It's contraindicated with patients with clinically significant portal hypertension, decompensated cirrhosis, or history of a decompensating event. 50% will have an inadequate response, but that's okay because we have options now. And in the POISE trial, between 10 and 15% of patients discontinued at the 10 milligram dose due to pruritus. But we learned something from that. Don't start 10 milligrams. Start 5, up titrate as tolerated. Okay, so this was a registry trial for OCA, the POISE trial. We got our primary composite endpoints for clinical trials in PBC from the POISE trial. So I'll tell you that once. It's ALK Phos less than 1.67 times the upper limit of normal, a change in 15% or higher in the ALK Phos, and a normal bilirubin. And those are the primary composite endpoints for all PBC clinical trials right now, continuing on today. In the POISE trial, OCA had a quick reduction in ALK Phos as early as 2 weeks. There was a 30% reduction in mean ALK Phos levels at 12 months, and individuals were 2.5 times more likely to achieve that reduction of ALK Phos of 15% or greater. So, of course, AEs are important to discuss, and in the POISE trial, pruritus was noted in many patients, okay? So 56% of patients on the titration arm reported pruritus, but that's through a 52-week period, and you have to know how adverse events are reported in a clinical trial. Patient comes in for a visit, you ask them, have they experienced any, whatever that thing is, and with itching, we queried every time, and so PBC is an itchy disease, so I'm not surprised with this, but OCA sort of got labeled as a pruritogen, which I completely disagree with. And if you look at the VAS scores over time in the POISE trial, baseline in all 3 arms of the trial were equal in terms of itching scores as what at the end of the trial at 12 months. So no change from beginning to end. Yes, people itch. Is the drug a pruritogen? Questionable. Again, and it wax and wanes. So what's the future of OCA? I want you to know that if you leave with anything, it's an even playing field. OCA has not gone away. The FDA they had a PDUFA date in October. They didn't reach full approval, nor was Intercept expecting full approval. There's ongoing use of OCA under accelerated approval while they look at more data. That's where we are today. So all 3 second-line therapies are at a level playing field at this point. What's to come for OCA, we'll see, because as we look at data, this is the path forward. There's some interesting work going on with combination OCA and bezafibrate. This data was presented at EASL in 2024, where 61.1% of patients on the combo achieved ALK Phos normalizations at month 6, and 66.7% of patients achieved complete biochemical response at month 6, and that means ALK Phos, GGT, AST, ALT, and bilirubin normalization. So numbers are pretty impressive, and we'll see what comes. But it's not going away. So what about the new kids on the block? So first of the new kids is elafibranor. Elafibranor is a dual PPAR alpha delta agonist. It was approved in June of 2024. It's for use in combination with UDCA or as monotherapy in patients who don't tolerate UDCA for whatever reason. The dose is 80 milligram tablet daily with or without food. It's not recommended in decompensated cirrhosis, and AEs included weight gain, GI distress, and fractures. So I mean, real world is going to tell us the story related to these AEs. Weight gain, this trial occurred in COVID. 23% of patients in the treatment arm gained weight, 21% in a placebo. GI distress was around 11%. which we're used to dealing with in any new medication. Fracture rate was 6%. There's no baseline DEXAs required to enter this trial, but we know cholestasis causes bone loss. And the treatment arm was more stacked with patients with bone disease than the placebo arm, but I'm not saying, there's no conclusions that can be drawn, but just be aware of those facts. So the ELATIVE trial was the registry trial. 51% of patients achieved the primary composite endpoints, and 15% of patients normalized their ALK phos. Normal ALK phos for this trial was 104 for women and 129 for men, so pretty low on the upper limit of normal for ALK phos in this study. Alkaline phosphatase dropped quickly in the first 4 weeks and then sustained over the 52 weeks of the trial, and the mean ALK phos reduction was 117 units per liter. So pretty impressive. There was also a trend for improvement in the worst itch numerical rating score in this trial, but it did not reach statistical significance through week 52, but the trend is encouraging. On entry, the mean score, it's a 24-hour recall of worst itch on a 0 to 10 scoring scale, and the mean score was about a 3.2 for these patients, so they weren't super itchy at baseline, and they reduced their score by 1.9 points during the course of the 52 weeks. So now what about seladelpar, the other new kid? Seladelpar is a PPAR delta agonist. It was approved in August 2024 for use in combination, again, with UDCA or as monotherapy. Dose is a 10 milligram capsule daily. It's not recommended in decompensated cirrhosis, so we have no therapy, second-line therapy approved for decompensated cirrhotics yet. So more room for improvement with PBC and more studies to come. Most common, this is a well-tolerated drug with the AEs, headache, GI distress, and dizziness most frequently reported. So 62% of patients in this trial achieved the composite biochemical response at month 12. Again, a rapid drop in ALK phos through week 4 and then sustained through month 12. The average decrease in ALK phos was 133.9 versus 16.9 in the placebo arm. So pretty impressive there as well. And as far as reduction of pruritus, there was significant improvement in the worst itch numerical rating score through 12 months. It did achieve statistical significance. So here's the summary for the new kids. Elafibranor is a PPAR alpha delta agonist. In the ELATIVE registry trial, the primary composite endpoint was achieved in 51% of patients, ALK phos normalization in 15%, and there was numerical improvement in the worst itch numerical rating score, not statistically significant, but still important. And with seladelpar, it is a PPAR delta agonist. 62% met the primary composite endpoint, with 25% normalizing their ALK phos. Normal ALK phos in that study was 116. So there was statistically significant improvement in the worst itch scores, and that is exciting. This category of drugs is an exciting development for PBC management, especially with its impact on pruritus. So what about long-term management of PBC in patients? So liver tests every 3 to 6 months, thyroid status annually, bone mineral density at time of diagnosis, and then every 2 to 4 years, depending on findings. Test for your fat-soluble vitamin levels at baseline, and then annually if bilirubin is over 2. Upper endoscopy every 1 to 3 years if your patient's cirrhotic or if the Mayo risk score is over 4. And also, if your patient is cirrhotic, don't forget HCC surveillance with ultrasound and AFP every 6 months. Take-home message, deep remission is where we want to be. Don't sit on your patients. If they're not responding to whatever therapy you have them on, you have options now, change it up. That's my advice. It's the best thing to do, I think, for our patients. New treatment options are here. Let's optimize treatment outcomes. New drugs can improve pruritus, which is exciting for management. And don't forget to monitor for AEs with this new group. These are new drugs. We have no real-world experience, and so be aware of muscle, kidney, and liver. Other safety concerns include cholelithiasis and cholecystitis and fibrates, drug-drug interactions, gastrointestinal side effects, allergic reactions. Now we're going to do a quick review of PSC. There's nothing new here. Let me just preface it with that. There's a long natural history. Median survival free of transplant is 15 to 20 years. There's small duct and large duct varieties. About 5% of patients will have small duct disease. Again, like PBC, a genetic and autoimmune association. Liver biopsy is not super helpful here unless you're ruling something else out or looking for autoimmune hepatitis, so we don't do it much. We do need help with PSC, so we need surrogates for clinical events to help us optimize clinical follow-up, to identify patients at high risk, and for design and endpoint selection in clinical trials, or we're never going to get new drugs here. So this is natural history, starting with early disease and moving through liver-related death or liver transplant. There's no intervention there, as you can see. It's just a pathway down the wrong flight of stairs, in my opinion. So there's competing outcomes, including cancers, bacterial cholangitis, IBD flares, and of course, impaired quality of life. It's a very highly variable course. ALK-Phos can be a surrogate marker for survival, and spontaneous resolution does not occur. So you start with cholestatic liver biochemistry, rule out other liver disease. Imaging now is MRCP for diagnosis. Endoscopic cholangiography is really reserved for intervention. Thank goodness, because I know we've all taken care of patients who had disastrous outcomes after an ERCP. So it's still necessary at times, but not always. Liver biopsy only if normal cholangiography and you're thinking small duct disease, or if you think there might be an overlap with autoimmune hepatitis. And don't forget colonoscopy. Everyone should have a baseline colonoscopy, and then yearly if they have IBD for cancer risk. So MRCP is now the standard. It is cost-effective and it's accurate. It's non-invasive. There's no radiation involved. ERCP we're still using for therapeutic intervention as needed, but remember it comes with sometimes a price tag for your patient, and that can be contaminating the biliary tree and causing cholangitis, pancreatitis. So whenever you do something invasive with your patient, please consider the impact on your patient, and is it going to change your management? And in my personal opinion, if it's not going to change management, do you really need the test? So that's the way I look at ERCP at this point. If it's necessary, it's great, but if it's not necessary, don't go there. Symptoms: fatigue, pruritus, jaundice. Up to 55% are symptomatic at time of diagnosis. And another 22%, if they're not symptomatic at diagnosis, will become symptomatic within 5 years. This is a bad disease. I'm just hammering it home. We need some help here. So hopefully there's some researchers in the crowd that are going to take over this challenge. Sleep is a problem with these patients, which obviously impacts quality of life. So ALK-Phos is a biomarker. This is a nice study of 366 patients out for 100 months, and it turns out that the optimal cutoff for ALK-Phos that points to increased risk is an ALK-Phos of less than 1.3 times upper limit of normal, reduces the hazard ratio, and so above that, you're more at risk for progressive disease. So treatment, there's no treatment. So there's no therapies that have been proven to prolong survival or change natural history. We direct treatment at complications and symptoms if and when they occur, and we monitor for malignancies. Primarily for cholangiocarcinoma, which can occur at any time. There's a 10 to 20% lifetime risk with 0.5 to 1% year-over-year increase. Highest risk with a CA19 over 130. So consider annual MRCP and CA19-9 for these patients. If they are diagnosed with cholangiocarcinoma, liver transplant is available as an option for a selected few with the Mayo protocol. Be on the lookout for colon cancer, pancreatic cancer, HCC, and gallbladder cancer in your patients with PSC. And this is why we look for colon cancer. These statistics are frightening. If you have colon cancer in combination with PSC, your risk from 10 to 25 years, look at that, 10 years, 9% risk if you have PSC and chronic ulcerative colitis, climbing to 50% at 25 years with that combo, as opposed to chronic ulcerative colitis alone. So don't forget your colonoscopies, please, please, please. So other PSC-related complications, cholangitis in up to 50% of patients, strictures requiring intervention, stones requiring intervention, bone disease, itching. Again, with any cholestatic disease, hypercholesterolemia, which you would treat the same. If there's cardiac risk, pay attention, prescribe statins. Fat-soluble vitamin malabsorption is there, so monitor malabsorption, pay attention to nutrition in your PSC patients, and look for other causes of fatigue. Don't just blame it on the disease. So imaging every 6 to 12 months with MRI, MRCP for both cholangiocarcinoma and HCC, a serum CA19-9 every 6 to 12 months. It's not about the number, it's about the trend, but remembering that 130 and up is associated with more risk. Cholecystectomy should be considered for gallbladder polyps that are over 8 millimeters due to the risk of cancer. And don't forget your colonoscopies again and again. So the take-home message is that this is a complex pathogenesis. You see a lot of patients on URSO. Standard dose URSO is safe but ineffective. High dose URSO is contraindicated in this population. There's no effective therapies. Alk Phos may be a biomarker, and look at that 1.3 times upper limit of normal as you risk stratify your patients into that category. Monitor for malignancies, I can't say that enough. Consider clinical trials if you have the option, and early referral to transplant centers is really important for those with disease-related complications. Sorry, I ran over. Thank you.
Thank you, Anne, for that excellent talk. Next, we will have Tuesday Werner, who will be speaking with us on ruling out drug-induced liver injury, immune-mediated drug-induced liver injury.
Thank you, everyone. First and foremost, I want to thank you all for spending your precious time with us today. My name is Tuesday Werner. I am from Mayo Clinic, Arizona, and for the next 20 minutes, we are going to talk about cannot rule out drug-induced toxic injury, immune-mediated drug-induced liver injury. This is my disclosure. So to streamline my presentation, there's a lot of ground to cover, but I'm going to start with a case scenario, brief overview of DILI and herbal and dietary supplements, or HEALY. DILI diagnosis, pattern of injury, its classification, phenotypes, drug-induced autoimmune like hepatitis or DILH, and immune-mediated liver injury from checkpoint inhibitors or ILISI, and evaluation and treatment. For our case scenario, this is our actual patient, a 42-year-old female with history of vitiligo, presented to hospital due to jaundice, pruritus, fatigue, abdominal pain that happened 4 to 5 days prior. She began taking Ayurvedic herbal medicine called Vitikaya, containing ginkgo biloba and Tinospora caudiphylla for 2 months. So we did all the evaluations. Serologic evaluation were unrevealing, including autoimmune panel, viral hepatitis, and there's no alcohol or acetaminophen use, no recent travel, no sick contacts. Laboratory tests showed ALT of 1100, AST 1000, Alk Phos 252, total bilirubin of 13, INR of 1.5, and platelet 260. Abdominal imaging were all unremarkable, and so we assume this patient have DILI or HEALY. So for the overview, there are currently more than 1,000 prescription medications available in the United States and more than 100,000 over-the-counter herbal medications available for purchase, and the average adult American receives more than 6 prescription medications per year. The annual incidence of DILI in the United States is 2.7 per 100,000. DILI is 1.6 per million, and HDS 43% of DILI and 19% of acute liver failure. HDS is not subject to pre-market safety evaluation according to Dietary Supplement Health and Education Act of 1994, and DILI is the leading reason why regulatory actions and market withdrawal. So most of these classes of drugs have been implicated as causes of DILI. Antibiotics, antiepileptics, analgesics, immune modulators, immune check inhibitors, and others like methotrexate, allopurinol, and amiodarone. The most common antibiotics is augmentin or amoxicillin clovenate, isoniazid, Bactrim or trimethoprim sulfamethoxazole, fluoroquinolones, macrolides, and nitrofurantoin. With regards to herbal dietary supplement, HDS is increasingly popular with social media, internet, source of infomercials. It is a huge billion-dollar market. It is not considered as a drug, so therefore not as treatment for a disease. It is considered as safe, natural, and relieve symptoms. It is, again, not regulated. And some supplements have multiple ingredients, making it more difficult to diagnose. For diagnosis, first and foremost, patient must have abnormal liver tests, and it is important to recognize when was the last time liver function tests were normal. By using the R-value formula calculated as ALT and alkaline phosphatase ratio, the pattern of injury is classified as hepatocellular, cholestatic, or mixed. For most of us, usually, we can identify the pattern of injury just by looking at the numbers. So increasing ALT and AST in out of proportion of ALP and bilirubin is hepatocellular. Increasing ALP and bilirubin in disproportion to ALT and AST is cholestasis, and mixed increasing ALP and AST and ALT. For clinical presentation, most of the patients are asymptomatic. Liver-associated symptoms include jaundice, pruritus, and sorry, it went too fast. For diagnosis of the diagnosis for DILI is a diagnosis of exclusion, and the backbone of DILI diagnosis is excluding other competing etiologies of liver disease. So we check for viral, we check for autoimmune, we check for imaging for obstruction, and we also check for history of hypotension, hypoxia to exclude ischemic hepatitis, and we check for alcohol and NASH. So currently there's no confirmatory testing and making it more difficult to diagnose. For DILI treatment and management, currently there's no reliable means to predict or prevent DILI. We rely heavily on patient's history, elevated liver test pattern, and clinical presentation. So we stop the culprit agent. Most of the time we don't know the medication that's causing it, so we stop almost all the medicines. So we monitor liver function tests, we monitor for the rate of improvement and patient symptoms. Most of us will not do rechallenge unless it's a special circumstance, and we continue supportive care. For classification of DILI, first we have the direct or intrinsic. It is dose-dependent, it is predictable, and the latency rapid onset in days. Example is the acetaminophen toxicity. So acetaminophen is very common and has been around since 1950s and commonly used worldwide. It is safe and effective. It sells over 1 billion tablets a year, and there are about 300 over-the-counter drugs and around 20 prescription drugs with acetaminophen, including like Norco. So it is the leading cause of ALF in the United States, and unfortunately 50% of these are unintentional. So the management of direct intrinsic DILI, we stop the suspected drug. If it's acetaminophen toxicity, if it's single time point less than 4 hours, we do NGT lavage, ipecac, we give activated charcoal, and acetylcysteine or NAC, orally or IV. Then we transfer the patient to liver transplant or higher level of care, and if they have coagulopathy and or altered mental status. Second classification is idiosyncratic. It is very difficult to diagnose as there is no rhyme or reason. It's largely independent, unpredictable, and the latency is variable. The third one is indirect DILI. Biological action of drugs and by affecting the host immune system causes secondary form of liver injury. Independent of the dose, just like idiosyncratic, and the latency is weeks to months. Example is the ICI immune check inhibitor and HBV reactivation after rituximab treatment. So the management for idiosyncratic indirect DILI, we check for other etiologies again, we check for serologies and imaging, we stop the suspected medication, and we transfer the patient to higher level of care if the patient have INR or altered mental status. We also continue supportive care. Now what about corticosteroids and idiosyncratic DILI? So currently, with regards to these corticosteroids, apart from cessation of the implicated agent leading to DILI, there is no standard therapy for DILI. Corticosteroids have been used, although the efficacy is unclear. So steroids is not associated with improvement, but it is associated with increased adverse events. There is this random prospective study showing improvement in women, hepatocellular injury, and autoimmune like hepatitis and hypersensitivity features. What about NAC for non-acetaminophen acute liver failure? So one of the study from Lee in 2009, most referenced article, this is a prospective double-blind trial with a primary endpoint of survival at 3 weeks and secondary endpoint transplant-free survival rate of transplantation. And basically they had 92 patients in the placebo arm and 81 patients in NAC arm. And the study showed that IV NAC caused reduction in NAC ALF mortality and need for transplantation, and also decrease in encephalopathy, hospital stay, ICU. It is a low-risk potential benefit, but high cost. So the clinical course, it can be very severe. 1 out of 10 patients can die or undergo liver transplant within 6 months of onset, and the remaining 1 out of 5 of patients have persistent liver injury for 6 months. So what about liver biopsy? So not sure what's going on. Maybe liver biopsy can help. The society guidelines recommendation with AGA, EASL, AASLD recommendations on when to perform liver biopsy in patients with DILI is hampered by low quality evidence, and so not very definitive. It's not mandatory and can be considered, it can be considered if uncertain. It is challenging because there's not one pattern of liver injury. And with that, there's all these phenotypes. With the direct hepatotoxicity, you'll see all these acute hepatic necrosis, sinusoidal obstruction, acute fatty liver, nodular regeneration, and most implicated agents underneath is the acetaminophen, niacin, aspirin. And with the idiosyncratic, you can also see acute hepatocellular, mixed cholestatic hepatitis, bland cholestasis, and the most implicated agent is augmentin, INH, nitrofurantoin, fluoroquinolones. And in the direct hepatotoxicity, you can see acute hepatitis, immune-mediated hepatitis, and most commonly from anti-neoplastic agents. Now, what if the patient from the previous patient we have a positive IgG or ANA? So we assume that this patient have drug-induced autoimmune-like hepatitis or DILH. Usually, this specific phenotype of idiosyncratic DILI features is indistinguishable from idiopathic autoimmune hepatitis, as it shares the same serological markers and histological features. Differentiating DILH from classic AIH is important, as patients with DILH rarely require long-term immunosuppression. DILH often resolves spontaneously after withdrawal of the implicated drug, whereas autoimmune hepatitis mostly require long-term immunosuppression. So for comparison of DILH and classic AAH, so immune-mediated hepatitis mostly have negative autoimmune markers and the liver pathology with panlobular hepatitis zone 3, hepatitis, mixed inflammatory infiltrate, including T lymphocytes, histocytes, scattered plasma cells, and eosinophils, whereas the classic autoimmune mostly have positive autoimmune markers and the pathology with interface hepatitis, lymphocytic, lymphoblastomycetic portal inflammatory infiltrates, and there's advanced fibrosis or cirrhosis. And of course, the treatment for autoimmune-mediated hepatitis includes steroids, mycophenolate, tacrolimus, and if getting really worse, anti-thymocyte immunoglobulin. For autoimmune, you can give steroids and azathioprine, as previously discussed earlier. What if the same patient have nivolumab or PD-1 for HCC a month ago. And so we assume this patient have ILISI or immune check inhibitor liver injury. So since the approval of the first immune checkpoint inhibitor in 2011, ICIs have revolutionized the landscape of cancer therapy, and nearly 50% of all solid tumor patients now receiving ICI-based mono or combination therapy. The 3 ICIs currently, I believe there's 7 ICIs in the clinical use now. CTLA4 or cytotoxic T lymphocyte associated protein, and PD-1 and PD-L1. So how does ICI works? ICI is a monoclonal antibodies administered IV infusions every 2 to 4 weeks that target either CTLA4 or PD or PD-L1. And the efficacy of the ICIs arises largely from their restoration of host T cell activity, and tumor-specific antigen. And the main effect of immune checkpoint inhibitor is to increase immune activity and against tumor cells by activation of T cells. But for some, it may reduce immune tolerance to self-antigens, causing immune-mediated tissue damage. So ILISI most commonly arises within the first 6 months of therapy. Most patients are asymptomatic, but minority of patients may present with jaundice, fever, abdominal pain. The laboratory profile, usually hepatocellular, 40 to 50%, and others present with mixed or cholestasis. Of note, concomitant immune-related adverse events involving other organs may be present, up to 10% of patients with ILISI at onset. This includes dermatitis and colitis, about 30 to 40%. And take note, liver injury, about 10 to 15%. Sorry, that's went too fast. And it's severe in 2 to 3% with cirrhosis and, of course, HCC. So for management, of course, we exclude other competing etiologies, other drugs, hepatotoxins, alcohol intake. We check for toxicology. We also check for PATH, or serum phosphatidylethanol. We check for viral, autoimmune. We check for imaging, obstruction, checking for metastasis and any thrombosis. And of course, we check for opportunistic infections if they have symptoms of fever or rash, including HSV, CMV, and EBV. For the management, ILISI depends on the severity of the presentation. So it is very important to work with oncologists and be mindful not to overtreat or to overdiagnose, as it can lead to stopping the ICI that is very important for patient survival. Clinical guidelines from oncologists recommend high-dose corticosteroids in patients with moderate to severe ILISI. In grade 2 hepatotoxicity, temporary interruption of the ICI therapy is recommended. And if the liver test returned back to baseline in 1 to 2 weeks, ICI can be resumed. For the dose of the corticosteroids, usually it's oral prednisone 0.5 to 1 milligram per day, and IV solimedrol methylprednisolone 1 milligram per kilogram per day. Now, put in mind that steroids also is hepatotoxic, so consider other immunosuppression if need be, if there's no response. So for histological traits of ILISI, there's again variety of all these findings at the biopsy, but basically there's no phenognomonic histological findings with ILISI. And for my takeaways, DILI is a diagnosis of exclusion, and management of DILH with immunosuppression is controversial and not evidence-based. DILH rarely require long-term immunosuppression. With the ILISI, it's one of the several immune-related AEs in 10%, about 2 to 3% severe ILISI. And ILISI treatment includes holding ICIs, corticosteroids use, and additional IS if refractory to corticosteroids. ICI can be restarted after ILISI resolution. And of course, liver tox is available online for reference for drug induced. Thank you.
Thank you for that presentation. I'm going to bring up Ms. Manshuri Adebayo, nurse practitioner now with Madrigal, formerly of University of Maryland Medical Center, and she's going to talk to us about some complex cases.
All right. Hello, everyone. Again, I'm Monshret Abayo. I'm a clinical practice liaison with Madrigal Pharmaceuticals, previously of University of Maryland, transplant hepatology. And I'll be talking about some immune-mediated liver disease, basically a case discussion just to have some fun. So we'll have the panel engage, and then in the audience, if you have any ideas of what's going on with the case, you can chime in as well, okay? And as you see here, we have a few emerging liver APP awardees that also contributed these cases today for us to discuss. And again, these are my disclosures. And so here we have a 62-year-old female presenting with nausea, vomiting, decreased appetite, and weight loss. Her symptoms started 3 months prior, but continued to worsen. She has a history of mildly elevated liver enzymes dating back to 2010 with ALT greater than AST. Pertinent history, type 2 diabetes, dyslipidemia, aortic regurgitation, some previous surgeries, appendectomy, tonsillectomy, hysterectomy, married, and so forth. You can see her social history. Medications, she's on Januvia and Trazodone. So her vitals were normal, her weight 183, so her BMI is 24.96. Physical exam, she's jaundiced, but it's otherwise normal. And so at this time, with just those general facts that she's, has nausea, vomiting, weight loss, and jaundice, is there any diagnosis you're thinking of offhand or that you want to evaluate for? Yeah.
So I guess I presume she was referred to you as for jaundice or a combination of symptoms.
I believe so, yes.
I mean, something obstructive, something malignant, all these autoimmune type disease processes,
Exactly.
PSC, those should all be in the differential. DILI for sure. Those medicines were not concerning that she had listed, but kind of doing a good medical history or medication history with meds and HDS, et cetera. That would be kind of my initial thoughts.
Good job, Tony. All right, and
I'd
so here
at least
are-
like to see some labs before I come up with a differential.
So let's
Thanks.
see what you have here now. So her platelets are 73,000, otherwise normal CBC. Her T-Billy is 6.1, AST 864, ALT 692, ALP 89, and an INR 1.86. Normal renal function, lipase is normal and negative screen for viral hepatitis. And then as far as her imaging, some gallbladder sludge with mild gallbladder wall thickening and trace pericocystic fluid, and no focal hepatic mass or intrahepatic biliary ductal dilation. So MRI to follow up on those ultrasound findings, and it showed marked gallbladder wall edema and biliary distension, filling defect, and wall thickening with mild cystic duct is present, and tiny sub-centimeter cystic foci throughout the liver, but otherwise unremarkable. And so given that finding on the MRI, she also then had a EUS performed with a fine needle biopsy, but nothing significant was found there. So additional labs that were drawn, see she has a positive ANA, positive ASMA, and a positive IgG. The rest of the serologic workup was unremarkable. And so this was the results of her biopsy that she had. So severe hepatitis with plasma cell-rich periportal activity and bridging fibrosis, suggestive of autoimmune features. And so her trichrome and reticulin stains highlight portal and periportal fibrosis with bridging and developing nodularity. So it favors Batts-Ludwig stage 3 to 4. So, Anne, what are we thinking now?
Me? autoimmune hepatitis
There you go.
with cirrhosis. This is not her first rodeo, it looks like.
That is indeed it. So she has autoimmune hepatitis and cirrhosis. And so this patient in particular was admitted for IV steroids. Okay, so with that, as you see on admission, her T-Billy was 10.3. You see her AST, ALT were all elevated. On IV steroids, all these things started to come down. T-Billy's down to 7.9. She was discharged home on oral prednisone taper and then given Bactrim for PJP prophylaxis. 2 weeks later, she's back. She's gained 33 pounds. She's jaundiced, and she has severe peripheral edema bilaterally and a particular rash on her abdomen. And so this is what she's looking like at this point. And these are her labs. So normal WBC, hemoglobin is 12.8, platelets is 71,000. Her T-Billy actually went back up, but her AST and ALT are still downtrending, also her ALP. Normal electrolytes and creatinine, and the INR is about stable, 1.62. So now what are we thinking that she's back, and these are the labs? Ladies?
I think the audience should be asked this question.
Yeah, anybody? Go on. No, she is she's on steroids and she's on Bactrim and she's back.
That's superimposed DILI from the Bactrim with address syndrome.
Strong work. So yes, she now has DILI from Bactrim. And so the bilirubin rose, but the alk phos was normal, arguing against biliary obstruction. Her transaminases improved from discharge, and they're arguing against worsening AIH. And the bilirubin is now downtrending after the discontinuation of Bactrim. So that's definitely DILI. All right, so great job on that case. Here's case study 2. So here we have patient NB, 65-year-old female who presents to the liver clinic for evaluation of possible PBC, past medical history of hypertension, hyperlipidemia, and status post-laparoscopic coli. In December 2020, she was hospitalized for symptoms of fever, chills, muscle aches, joint pains, difficulty walking that developed about 4 days after starting atorvastatin. And these are her labs here, so very elevated AST, ALT, ALP, and T-Billy, just 1.3. So here, this just gives you a list of her medications, prior smoking history, history of the laparoscopic coli, but not much there. The ultrasound was overall unremarkable, but showed some hepatic steatosis. That's basically the finding that we see there. She was evaluated by GI and was discharged home after 2 days. And they concluded it was viral with myalgias, fevers, and underlying fatty disease. So the plan was to follow up with primary care and then GI for further evaluation. So she had a liver biopsy in 2021, and at that time, the findings basically showed that she had some chronic cholangiopathy, some mild steatosis with steatohepatitis, and everything else you see listed here, but those are the major findings there. And so in the absence of an infectious etiology, the differential, includes PBC, drug-induced hepatocellular injury, and less likely bowel duct obstruction in her case. So she was told she had a diagnosis of PBC, and she was prescribed ursodiol, but she was unable to tolerate it, and so she discontinued the medication, and she was lost to follow-up. So now she's back. It's October 2024. Her weight is 201, height is 5'2", so her BMI is 36.8. She denies any symptoms of pruritus, fatigue, abdominal pain, nausea, vomiting, or dry eyes. Her current medications, as you see listed there. And then her recent lab review, you see from 2023 in May. Everything looks pretty normal, and same in May of 2024. And we'll kind of review where differentials are when we take a look at this. So she had a FibroScan performed on October 4th, and the FibroScan showed stage 2 moderate fibrosis and a CAP score of 297, so we're talking S3, severe steatosis. And as you see, her labs listed here, still pretty normal AST, ALT, but the ALP is up. T-Billy is normal, but she has a positive AMA. Also has increased total cholesterol, lower HDL, and then increased triglycerides and LDL. Okay, so what diagnosis are we thinking now with those labs? Given her previous history of possible PBC and then the biopsy showing,
I mean, she had a biopsy that looked pretty convincing for PBC. However, her current alk phos off of treatment isn't very impressive. I'd still go with PBC. She doesn't tolerate URSO, which I would find out what the intolerance was before I gave up on URSO. She absolutely wouldn't take it. You have multiple choices for therapy now. All are approved.
Yes.
All the second-line therapies are approved for monotherapy in somebody who doesn't tolerate URSO. She's not itchy. Like, the choice is up to the
is
provider.
that to the provider? Yeah, absolutely. Anything else that sticks out?
So she's like 3 for 3, right, with an AMA positivity,
I mean,
biopsy proof, and alk phos elevation. So yeah, I think PBC would be the appropriate diagnosis.
Yes.
I mean, yeah, you can't forget about the NASH, and that cholesterol is not typical of PBC either. She had a low HDL. She has metabolic risk, but she didn't tolerate statins. She had a DILI kind of, like, so I would further explore options for her in terms of managing her cardiovascular risk, for sure.
Oh, yes. She did not. She had just that EUS following the MRI. But you're right. Oh, you go ahead.
Can you put add your comments about a role of MRE for this person? If we had a do we have a strong feeling that this could be an atypical presentation for MASLD or MASH? And is it just the PBC we saw in biopsy, or is there maybe just an atypical presentation for MASLD with the alk phos elevation? Because we see that, it's unusual, but is there a role to rebiopsy or consider MRE?
That's a good question. So with this patient, well, they could have done another biopsy. That is possible. However, with seeing that she had those chronic changes with the cholangiopathy, I think holding on to that, with also seeing the metabolic risk factors in her labs, they were thinking just combination of PBC and MASLD and possibly starting there. But
Can you go
good
back to the
questions.
biopsy results
let's go
from
back.
whenever? I thought it was interesting that she had like a 6-month biopsy after all that business.
I did too.
So, I mean, this said mild steatosis, 5%,
And this
without
was 2021.
2021. And then I think her weight had changed over time.
Right. That's what I said.
So then she came back a few years later, right?
Yeah.
So, the slide previous. So I think she's gained some weight. She just came back for a delayed follow-up, I presume?
Yes.
Maybe
Lots
to
of
go over those
follow-up.
biopsy results from 3 years prior?
Yep.
So we do a FibroScan, 8.1, 297. That's really, I mean, I would argue that that's maybe not S3, maybe more S2 steatosis. So we have diagnosis still of some steatosis. 8.1, I think I would agree with Elizabeth that if you really want to truly understand the degree of fibrosis, that now here 3 years later, you can consider non-invasive biomarkers or an MRE as a better means. But I think then you still have the question of that alk phos and the previous cholangiopathy, and then now we have an AMA positivity with high ANA, I'm sorry. So this could be very mild PBC with MASLD. I think that's appropriate. And then you have kind of a different scoring system for your fibrosis on elastography with, is this PBC we're using as our cutoff, or is this fatty liver, or both? So an 8.1 with 2 different diseases is probably less concerning than just one. So, but
Yeah.
MRE could be considered for sure.
I live in the land of no MRE because it would never be approved. So that leaves me with other non-invasive biomarkers, which I don't know if it would give me a whole lot of information, if they would. I mean, an ELF is out there, like,
And Dawn?
I'm just not sure in this case.
PBC would definitely still be my differential because an alk phos of 150 is not normal. But we also definitely see mildly elevated alkaline phosphatase with NASH. I would consider rebiopsying her because I think that first biopsy, that could have been an autoimmune presentation with atorvastatin, which is the type of presentation we can see with those injuries. And I know a lot of times we discount statins. And for a long time, I've been doing hepatology for 20 years. I've never seen a statin-induced liver injury until you see it. And that's when we put this, this talk as a whole together. That was where the DILI piece of it came from, because we get these biopsies. It's like, could be this, could be that, can't rule out autoimmune, could be drug-induced liver injury. And then you're like, okay, now what, realistically, what do we do with that in these situations? But I would, to some degree, question, could that original biopsy have been DILI from atorvastatin? Because I also wouldn't expect somebody to go to F2 fibrosis in just 2 years. But again, biopsy is not great staging fibrosis either, but I think there's a role potentially for her of repeating a biopsy, or if nothing else, having that discussion with her and like kind of giving her some options. Like, these are some of the things we can try. If we put you on URSO and that ALK-Phos improves, well, there we have our answer. But if you're that far against it, we could consider doing this.
I mean, she was only on statins for a short time, and her histology showed bile duct proliferation. So I feel like that is more of a chronic finding. Somebody who's had ongoing issues with their cholestatic situation. So I'm still leaning towards PBC.
AMA too for me.
Yep, the AMA.
That's a very positive.
But great thoughts.
Thanks, Tom.
Yeah, I have a few questions. First is the AMA M2. Was it done or no?
I don't have that information available. It's someone else's case.
I would
but-
think that would be more specific.
Yeah.
And with such a high ANA titer and AMA both positive, it is something surprising, very high ANA titer in this. And with this high ANA titer, I'm not sure IgG levels are very reflective. Do we have IgG levels?
I
Because-
think her last IgG was
So-
noted in the earlier case, but not
Yeah.
here.
So my first question would be in IgG and high ANA, what is it? Second, if it is M2 positive or not. And third, the TG and the cholesterol can also be high in PBC. So I would not put another diagnosis with PBC. So if we consider the previous biopsy to be correct or rightly interpreted, then we can review, but a second biopsy with an M2 with an IgG would probably pave the way.
Thank you. And so in this case, she was diagnosed with PBC and MASLD or MASH. And so as Anne was discussing, would you consider, elafibranor, seladelpar, given her past intolerance to URSO? And then also with the MASLD or MASH, counter her own weight loss, increase physical activity, treat those metabolic risk factors, and consider medication therapy with resmetirom. And then any final thoughts and pearls from the panel?
Living in a place where MRE is widely available, I would probably still do the cholangiogram just to make sure there wasn't evidence of large duct disease.
I think just personally, it's all experience kind of thing. If you've had one biopsy with really no major findings and kind of a low-level FibroScan and normal AST and ALT, I don't know if I would want another biopsy myself nor order one. So I think I would try to manage this initially as PBC, and then I would really I'm very anti starting multiple medications for different things at the same time. So this last slide, I would not do URSO and let's do a combo of both. It would be let's do the ursodiol. Is that going to help, bring the ALK-Phos down? Repeat a FibroScan in the future, and then you can kind of, this patient deserves long-term follow-up, but I don't think there's anything urgent or acute. You need to jump to another biopsy, or even you can even hold off the MRE for.
Yeah, I
6
feel
to
like a
12
liver
months.
biopsy for somebody who has near normal labs would not be diagnostic. Like, you might just get a bunch of nothing for sticking a needle in somebody's liver. So.
Absolutely. Great conversation. All right, and then this is the last case study. We'll run through this one quickly. And so this is an 81-year-old Korean female with a medical history of hypertension, hyperlipidemia, type 2 diabetes, thyroid polyp, and recurrent UTI. She was referred to the HEP clinic for evaluation of elevated LFTs, as you see to the left there. She reported taking albendazole 400 in mid-July, followed by a repeat dose 2 weeks later. And just some background in North Korea, due to some poor sanitation and limited awareness of food safety, they were doing a deworming campaign, and so many people were receiving this medication in 2 doses. And so this was done, in schools and public health centers, and the outcome is it reduced the prevalence of parasitic infection in Korea. And so the timeline for this patient, prior she had normal liver enzymes. She took the albendazole 400 mid-July and repeat in 2 weeks. And as you see her labs in September of 2024, they were elevated AST, ALP, normal T-bili, and then GI repeated labs a week or so later. Her LFTs continued to rise. And then by hepatology, she still had very high LFTs. And so she had a positive IgG and positive ANA and everything you see listed here. She was negative for her ASMA, AMA listed here. And as you see, the other labs that were negative. So she had a fiber scan and she had normal F0 to F1 fibrosis and CAP score with no steatosis. And also listed here, her ultrasound was pretty much unremarkable. Okay, and so in interpreting this, we see that, due to significant transaminitis and positive ANA and elevated IgG level and unremarkable findings, she likely has autoimmune hepatitis, which was strongly suspected and triggered by the use of the albendazole. So the albendazole therapy can cause some transient asymptomatic elevations in serum aminotransferase levels in up to 50% of patients, which typically resolves quickly once the drug is stopped. And although a liver biopsy was recommended for a definitive diagnosis in this patient, she declined the procedure due to her advanced age, and she opted for empiric treatment. So what treatment would you give this 81-year-old female for AIH induced by the albendazole?
Steroids is a consideration, but I would not for an 81-year-old. So most likely this is daily and it's time.
And so in this case, this provider actually gave her budesonide, which was the interesting choice. And this is what her labs look like following. So it's a question of what time things just going down or if it was, helpful in being effective at all for this patient. So although a liver biopsy was not performed, the clinical presentation, was suggestive of autoimmune hepatitis, given the elevated autoimmune markers and rapid response, and that this patient is still currently undergoing follow-up. Okay. So I think that's our time. Thank you guys, and thank you.